Hi, everybody. I'm going to find my chat. Where's the chat box?
We're not going to be able to eat during class anymore.
Why not? Why can't you eat?
Well, during the summer, because we're actually going to be there.
Oh, right. Yes.
So it's not going to be like, we can just like, be making mac and cheese or something,
Before COVID, everyone used to eat in the classroom a lot. So I hope one day you can eat in the classroom again. I don't know when that day will be, but hopefully in the not too distant future.
So will things still get posted, Leslie, like PowerPoints and stuff like that, like on Moodle?
Yeah. So even before COVID, the first 2 years, I would put all, and I think a lot of the other faculty would do this. We'd put all of our PowerPoints on Moodle. We'd put assignments and submission places on Moodle. We'd put quizzes and exams were on Moodle. So we used Moodle a ton. We just didn't rely on it as heavily to like for you guys to go in and get the majority of like your learning from there, because you'd come to class and listen to the lecture and stuff like that. But we've always used Moodle for I think a number of years. So they'll still put everything, all the resources there. You just, and they, in the past, before COVID, they even recorded lectures in the classroom. So, and then would post them on Moodle. So you could go back and re-listen to the lecture. Sometimes it was just audio, but other time, well, yeah, it was always just audio. There was never a visual of whoever was instructing, but at least you could go back and, listen to it.
Yeah, I think that's helpful.
Yeah. Yeah.
I listen to lectures a lot.
I think
I'm bombarding you with emails. Sorry, like, where's the lecture? Where is it?
I need that lecture. I think it's nice, especially if you have a commute, because it's kind of a way to fit in listening to it. Like if you have to fit it in and that's like your main study thing, it can be hard. But if it's like you've listened to it and you've written down notes and then you can listen to it while you're driving, and it's like it just kind of, the more times it just kind of gets into your brain, hopefully, the repeating it.
The thing that I've noticed with your class, I'm not sure. Sometimes the way you guys post it, Katie posts it through YouTube, so I can listen to hers while I drive. But yours I can't because I can't pull it up on my phone. Like the link doesn't work on my cell phone. I have to use my laptop. So it's weird. Sometimes I've been able to pull yours up in the past, but I don't know why it's different now.
Well, I usually upload it from Screencast. I usually upload it to YouTube, but then it might be how I put it in Moodle, because it is a YouTube link, but it might be the way that maybe what I need to do is post the link differently in Moodle, because I usually link it into a page, which may do something funky that your phone doesn't like. But maybe if I just posted,
I don't want to say anything to you because I feel like I
link
what time about the lectures.
Well, it's not a big deal. I could post it like 2 different ways. And I mean, we could just see if it works, or I could ask Katie exactly what she does. That would be even simpler, because it's probably the way that we're posting it, because I do keep mine housed in. You can always ask me and I'll just email you the direct YouTube link. And
yeah, that would be helpful because I do like re-listening and what you, sorry guys, I'm like taking up class time. I do listen while I drive because you and I have the same drive.
Yeah,
so
it's a good 45 minutes, a little longer for you. But yeah, I can always send you the link. Okay, so you guys can start the quiz. If you don't get the grade you want the first time, you can have a second try. So don't worry. Go in and good luck.
Leslie, you're so cute.
My spring break gift. Tell me when you're all done. Hopefully it shouldn't take you very long. And if you get it wrong, then I can tell you what the answer is, and then you can go back and do it again.
If you haven't seen this movie, you're really missing out.
It's a must see.
It's amazing.
R.I.P. R.I.P. Robin. R.I.P.
It's also on Hulu right now. If anyone
Oh.
hasn't seen it, it's on Hulu. So.
I don't think I've seen this movie because I don't know this quote.
I just clicked away from the camera. Who said that?
The other movies, though, to be able to be like, okay, that's not in any of the other movies.
That's just not okay. No, it's totally fine if you haven't seen the movie. Now you know an excellent movie to go see. And I see not all of you have dialed in the answer yet. So should we just say what the answer is? Does someone want to say the answer?
Dead Poet Society.
The Dead Poet Society. And Robin Williams is always one of my favorite actors. I loved him so much, but that movie is such a tearjerker, and it's just a good movie. So I highly recommend it.
I'm pretty sure my senior year of high school for spring break, the day before, like the Friday before class ended, that's what we watched in my English class. She's like, I love this movie. We're just gonna watch it as like a day off before spring break.
Yes, it's such a good English class movie. That is so
We
good.
should watch it today during our class.
We should. Frankly, I'd rather be doing that too right now. Then because this
Thank you so much for for having no quiz today.
You're welcome. Well, technically there was a quiz, but we can't say it wasn't a quiz. It just was a very easy quiz.
This was the best quiz ever. So
yeah, I know. Well, I thought I was gonna do like one that was like multiple movie quotes, and then I thought, no, that's just gonna waste time. We'll just do one and have it be fun and get over with. Okay. So I just wanted to also say, hurrah, it's week 10. Seriously, that's really fast. We only have really 4 more, after today, 4 more weeks. And the last class for this class is a review. We'll spend 2 hours just reviewing all kinds of things that may be on the final, so that you guys feel like, we have lots of time to prepare for that. So that'll just be a total review class. And then week 14 for this class is the exam number 3. So it's like you're going to have an exam number 3, and then we're going to review for your final. So it's a very strange way that it kind of all culminates, but I guess that's just the way it is. And so after today, the 3 lectures that remain, the way it's going to work, and I hope you guys don't mind this, it's going to be a little weird. There's typically guest speakers that this class used to be on Thursdays. So there was guest speakers for like 5 of the weeks. And, but 3 of the speakers can't do Tuesdays because of their schedules with pharmacology. So they said that they would record like a 50-minute, their lecture. So I'm going to play it. We'll either play it first off, and then maybe we'll do an activity at the second half, or we'll do an activity and then we'll watch their video. But I want to play it in our class time, just so and I can pause it if somebody's like, we can like pause it and then get it going. But at least it's a time that I know everyone will watch it. We can ask some questions because it'll all be here live. And so that's what I'm going to do for the next 3 classes. So it's going to be a little weird because we're basically going to watch like a different professor lecture on those topics, but at least there's opportunity for some conversation and questions and that sort of thing. Does anybody have any questions right now? If not, I'm going to pull up the PowerPoint. Let me find it. I have literally 10 PowerPoints on my laptop right now. Let me find the right one. Okay. Get back up to the top here. So this PowerPoint, I was going through it. I opened up the one in Moodle, and that one was like straight out from, last year or the year before. And then I was going through it, and there was a couple things I was like, meh. And so this PowerPoint that I'm going off of is very slightly different, not so different that you guys have been like studying the wrong material or anything. But I will post this one at the end of today so that any like minor changes you'll see for this one. So you'll have both of them, but it's not major differences. It's just a few things that I didn't quite like as well.
So is this slideshow the one we should mainly focus on for studying the test?
I think so. I mean, I don't think probably for the way the tests are written, there's still probably either one would be fine, but I think I would just probably focus on this one.
There's no way you can post this so I can take notes on the correct one now.
Oh, post this one now? Yeah, let me see.
I'm sorry. I just like taking notes when you're
On the
and
PowerPoint.
on the PowerPoint, and I don't want to take it on the wrong
one. Let me see. Hold on just a second.
Sorry.
Not a problem. It'll just take me 1 minute to grab it over here. Share. I have to remember to make it shareable. Almost there. I'm just going to label it PowerPoint just for the sake of not having to type as much. Okay, so it's in Moodle now. Probably at the bottom of week 10, just as PowerPoint. And I can rename it later. Okay. Okay. So this week to me, it took me a second to kind of be like, what are we studying? Because there just seemed to be such like infectious diseases. I was like, okay, infectious diseases. And then there just seemed to be such a mishmash of things that I kind of I don't know, it in my brain. So I thought, well, if I don't feel like it, the titles and flow, maybe you guys might kind of be like, what are we studying? Because it's just a little bit of this, like Cushing syndrome is just popped in there. And then we're talking about osteonecrosis. And, it's just all these different elements that are all important, but it's just, I don't know. I think I'll probably tweak it far more next year, but we're gonna, my goal for this year is to get familiar with the flow of the class and then tweak it, because that's just works better for me. But if you guys have any questions about where to find this material in the textbook, it is a little piecey. So it should be written, I think, fairly clearly, like there's a little chapter 8, chapter 9. I think it says the page numbers, but it does just kind of jump around a little bit. And then for the herbal medicine portion, that fairly lengthy article, which I don't know if everyone's read it all the way through. If you read the abstract and then you kind of skim it and look for some of those things that were specifically asked in the handout, that will kind of help you chunk it up a little bit better. It's a good article. It just had a lot of content. So, and I'll make sure that I kind of give you guys an idea of what to dial in on for any, because there will be some exam questions for herbal medicine. So I'll kind of help you guys dial in on what to focus on, because there was a lot of stuff in that article. So that could be a
There
little
won't
bit.
be a PowerPoint for that.
There is not a PowerPoint. I could create a PowerPoint, and I think I would definitely create one for next year. I think if for this year, what I'll probably do is I'll just make sure that the study guide gives you guys what you really want to focus on. I think the handout does that quite well, because bleeding is one of the big things with herbal medicines. There's not a ton of hugely significant things that we have to worry about, but bleeding is a very common thing. And then there might just be some kind of random things that some people will experience when taking herbal supplements. But that's probably the biggest take home point is there's several herbal supplements that can have a gingival bleeding or a antiplatelet or kind of an action. And then if patients are taking aspirin on top of that, then that could just increase it even more. So that's kind of a big take home point for hygienists. And then there are some other things, but I feel like that's going to be something that if it's on for an exam question, it'll probably be something along that line, but I'll be sure to kind of give you guys an idea of what else to focus on. So for the objectives here, there's a lot of different objectives. We're talking about HIV and AIDS. We're talking about tuberculosis, rheumatoid arthritis is covered. The corticosteroids is kind of what led to the Cushing's syndrome, because that can happen if somebody's been on Cushing's syndrome, can be caused by other things. And I think I got a little bit confused as to why it was in there at first, because it didn't really, and then I was like, oh, I see, they're talking about, but when you look up Cushing's syndrome, it doesn't necessarily go to excess corticosteroids. It could be tumors on the pituitary gland or something like that. So I thought, well, if I got a little off track, maybe you guys might have been like, why is that in there? But that is why it was essentially in the PowerPoint for the originally. And then talking about components of the function and components of the blood, and then the cancer. So the cancer treatment is and all the drugs that can be in cancer treatment is such an immense topic. And so we kind of are trying to distill it down to and we talk about this actually far more in special needs. So you're not going to really be expected to know drugs and drugs and drugs for chemotherapy, like tons and tons of names. We're kind of looking at some of the major oral manifestations, a few drug names and classifications. And then the same thing with the bisphosphonates. We want to know the bisphosphonates, some of the main names there, because that can be used for patients who have cancer, as well as somebody who has osteoporosis or a number of other conditions. They use bisphosphonates for several different conditions, and then those complications. And again, so at the end of this, it almost made me feel like, I thought to myself, boy, this feels almost more like what I cover for special needs, because we talk about these major oral implications. But there are some slides with the drug names, and you need to be familiar with the drug names. So it's kind of like it's almost like we're blending a little bit, but then when we reinforce it next year with special needs. So it's just kind of a little bit of everything today. And then PowerPoint doesn't have any of the herbal medications or herbal supplements. So the first one here, so AIDS and HIV, we'll talk a little bit about that. So the first reported case of AIDS was in the 80s, although I have seen some documentation that said earlier, but I think the generally accepted, wide accepted case is that the first case was acknowledged in 1981. And AIDS is basically the end stage infection of the human immunodeficiency virus, or HIV. So that's basically like someone can live with HIV for a number of years. And nowadays, because of medications, sometimes they never convert to AIDS, to that end stage, but generally speaking, with their health and depending on how treatment's going, it can eventually kind of change into full-blown AIDS. So essentially the virus is attacking the host's immune system. And so then they become incredibly susceptible to all sorts of opportunistic infections. And that's generally what leads to death or serious illness, is all of these things that your body just can't fight off anymore, because your whole immune system is just completely compromised. So various infections and cancers. So HIV infects a type of white blood cell called the CD4, or a T lymphocyte cell. Or they call it a T helper cell. And then, so these cells keep us healthy. They fight off our infection. They're part of our immune system. And that HIV virus kind of latches onto that cell. And that's the initial stages of it. I have a nice picture coming up that goes through these steps, which I think I'll kind of talk through it a little bit slower with the picture, especially for people who are visual. But HIV cannot reproduce on its own, so it kind of hijacks our own T helper cells, or our T cells. So the virus attaches itself and fuses, and then it takes control of the cell's DNA, and it makes copies of itself inside of this T cell, or the CD4 cell. And it finally, after it's made copies of itself, it releases more HIV into the blood. So once it's able to replicate itself inside of our T cells, then it starts releasing the virus. And HIV will continue to multiply and spread through the body. And this is called the HIV life cycle. So it's just like a little factory. Your immune system has become a little HIV reproduction factory. So this is a picture of a little schematic of an HIV/AIDS virus. And inside here, you can see here's the RNA and the integrase. These are all the little parts. This is the part that latches on. These little proteins out here on the end latch onto our T cells. And then it dumps, once it gets inside of our cell, it dumps its genetic material into our T cell, which I'll show you a better. I love this. This is the graphic that I use in special needs, just because it's cool, because it's like an all-in-one graphic. It looks like a lot of stuff when you first look at it, but it goes through these steps and then these little stop signs. This is what's really nice for our class, because these little stop signs are the different drugs that can be used, the different classifications of drugs, and then you can actually see where they're working in the process of the HIV life cycle. So first you have the binding and the fusion. And so the HIV virus binds to the outside of the T cell, and then it kind of starts to go inside to the cell, and then it dumps its genetic material inside the T cell. Now, if somebody's taking a medication, this is one of the classifications that you'll need to know. If they're taking a fusion inhibitor, they're going to block the HIV virus from being able to merge with the T cell. So they're just like blocking it right there at that stage. So that's a fusion inhibitor. That's one type of drug that somebody may take. And then the next step, so now the genetic material is inside of our T cells, and the HIV RNA takes this reverse transcriptase. That's the enzyme that changes it from an RNA to a DNA. So now it's an HIV DNA. So at first it was an HIV RNA, but now it's a DNA. So now it can actually use its DNA to change our DNA. But then again, you can see at this stage, number 3, if somebody's taking a non-nucleoside reverse transcriptase inhibitor or a nucleoside reverse transcriptase inhibitor, it's going to stop this change from RNA to DNA, and the HIV RNA can't do much. So if it doesn't have the ability to change to DNA, then it really can't affect our RNA, our DNA. So that's another classification of medications that people take for AIDS, AIDS therapy or HIV therapy. So then the next one, then we go down to 4, integration, and this is where the HIV DNA integrates with our DNA. And then you can see someone could take an integrase inhibitor. That's another classification, and that would prevent their DNA, its DNA, whatever, from merging with ours. And then the final couple stages is when the new altered DNA comes out of the nucleus, and then it's going to replicate. So replication, once it's integrated in the CD4 cell DNA, HIV begins to use the machinery of the CD4. So it uses our own replicating machinery to make more of this new HIV DNA, HIV/human DNA, to just make more of it. And I'm in the way of my protease inhibitor. So then the last one is a protease inhibitor. This is budding, which means that the HIV can come out of the cell and now it can float around our body and cause all kinds of issues. So it would stop newly formed, immature, I can't read it because it's too small, but maybe you guys can see it. It pushes itself out of the host CD4 cell, and the new HIV releases protease, which is an enzyme, and this protease acts to break up these long protein chains. But if it's being inhibited, then that step can't happen. So we'll get to it in a second, but generally patients who have HIV, they take multiple drugs that try to control this conversion process on many levels. So they don't usually just take one thing. They usually take a series of medications to try to control HIV from replicating in the body, from being it's like the serous level of HIV in the blood is sometimes so low you can't even detect it. Sometimes they don't even test HIV positive anymore, even though technically they do have it. It's just so suppressed because of the drug therapy that it appears that they don't have HIV anymore. So they've gotten very successful at treating HIV. Okay, enough time on this slide. I just like that slide. This is basically the same thing, just to me, not nearly as readable, but I left it in there because some of you might like this slide better. So I just left it in there, but it's essentially kind of going through the same process. Okay, so now what makes somebody go from HIV to AIDS? So a decrease in your CD4 or your T cell count occurs as the disease progresses, and if it's not being controlled or treated with medication. And so as your own healthy T cells decrease, you're obviously going to become more susceptible to opportunistic infections and all kinds of different things, cancers and stuff. So some just examples of that is tuberculosis, of course, candida, fungal infections, systemic, but oral thrush would be a big one that you'd see, but anywhere. Different types of pneumonia, bacterial, and then PCP pneumonia, and then GI issues, meningitis, and then cancers such as the Caposi sarcoma and non-Hodgkin's lymphoma. And we'll talk a little bit about the Caposi sarcoma in a minute as well. So basically you get to a certain number count of the CD4, and then you have been classified as changing from HIV to AIDS. So if the CD4 or the T cell count goes below 200, then basically your diagnosis is AIDS, acquired immunodeficiency, as opposed to HIV. So below 200 in your CD4 count or yeah, CD4 count.
So Leslie,
Yeah.
that means that if someone has like 201, that would be AIDS, right? And then less than 200 is HIV.
I think it's opposite. So wait a minute. Am I thinking about it right? Let me look at it again. Less than 2 changes your diagnosis. So if somebody has 199, they're AIDS. If they have 201, they still have HIV.
Gotcha. Okay, opposite. Gotcha.
Okay, so for treatment then for HIV, they call it heart therapy. And next year, hopefully we can have this guy come and talk. He's a individual that's been living with, I believe he has AIDS, or does he? I'm actually not positive if he has HIV or if he has AIDS. Nevertheless, he contracted it in the early 90s in a time when everybody was pretty much very sick and high chance of dying. And his story is really interesting. And he's come in for a number of years and talked to students. And so hopefully he can come in person. He recorded a video for the seniors last semester, but it just didn't hold the same weight. It's just really neat to hear his story, and he's so interesting to listen to. And he's just really lucky, but he has gone through so many medications and to get to the point where he's at. Nowadays, people, it's much more kind of like, here's your medication, you'll probably be fine. Whereas when he first was diagnosed, it's like, use this for a while. Okay, now it's not working. Now use this for a while. Okay, now it's not working. And it was just like on and on and on. And a lot of people, got sick and died. But he actually moved from the South, like, I don't remember if it was Alabama or something, where the healthcare probably wasn't as good. And he came out here and had treatment, I think at OHSU, and had much better progressive, like newer treatment. So it's just really interesting to hear him talk. So hopefully you guys will hear him next semester. Anyways, heart therapy, which is stands for highly active antiretroviral therapy. It's basically consists of like multiple steps of these different inhibitory medications of these different markers in the whole process. So it consists of 3 to 4 drugs typically. And then certain classes are used more frequently. So the 2 types of the or the nucleoside reverse transcriptase. So there's usually 2 of those, and then a highly active protease inhibitor, which if we go back and look, protease inhibitor is at the end. That's at the very end. And that's the most common kind of grouping, but it's basically like a grouping of multiple. I don't know if it's different for every patient, if they do different amounts. I'm not sure about like dosaging and exactly, and I don't think you guys are not going to be tested on that kind of thing, but just knowing in general that it's multiple drugs and it's referred to as heart therapy, HAART.
Leslie, can I ask a question?
Yeah.
So the nucleoside reverse transcriptase, that's inhibitor. That's the one that inhibits the enzyme that changes the RNA to DNA.
The reverse transcriptase. Yep. So that little green thing. Well, I'm looking at the wrong one. Let me do it up here. I always look at the one that you guys can't see on the video. So this little green ball here, the reverse transcriptase that turns the HIV RNA to HIV DNA, it inhibits that. So there's a non-nucleoside and a nucleoside. I don't really know what the difference is, but one is one and one's not. But other than that, they both inhibit the reverse transcriptase. So there's usually, according to the heart therapy, they usually use 2 of those types of drugs in the cocktail. It's like a drug cocktail.
So like that's what you would call like the heart therapy is like all the drugs they're taking to control the disease.
Yeah, yeah. And I mean, if you have a patient that has HIV and they write heart therapy, you may say, do you just take one pill and it has lots of different drugs in that one pill, or do you take 4 different pills? Like, you could talk to them about it, and then maybe they would write down the different actual drugs. You know, I'm not sure. When you guys go next year, if you're able to go to Russell Street, that's where there's a large population of HIV patients that you see. We've always gone there in the past on rotation. I don't know if the seniors are going this year or not because of COVID, but that's a wonderful opportunity to see in action, like medical histories and the drugs that are on those medical histories and that sort of thing. Okay, and then here's pretty much the same slide, but just with, this is a similar one to the other one. It's kind of showing where the drugs, the entry inhibitory, the protease inhibitors prevent it from sending it back out into your body. The reverse transcriptase keeps it from going from RNA to DNA and so forth. So now we have some actual drug names. So here we have the nucleoside reverse transcriptase. These are some drugs in that category, some examples of drugs in that category. You can see the VIR, VIR is a common, it's not always a suffix because it's not always on the end there, but you can see that VIR is a commonality. So when you see something VIR, it usually is related to something that's viral. So similarly with like acyclovir for herpes simplex. So it's usually kind of gets your mind thinking viral. It's treating something viral. There's only one here listed non-nucleoside reverse transcriptase, that's Sestiva or efavirenz. And then there's the protease inhibitor and the fusion inhibitor. So this is kind of if you want to think about it in a systematic way, the fusion inhibitor is the first thing that it would stop the virus from coming into the cell. The nucleoside and the non-nucleoside keep it from going from RNA to DNA. And then the protease inhibitor is toward the end of the HIV life cycle. So this isn't in numerical order, but if that helps you, it would be 1, 2, the nucleosides would be 2, and protease would be 3 in the life cycle of the HIV. But a patient's just going to pop the pill and it's just going to all be in their system. So I don't think it really matters, but if it helps you know what each one does and connect it to the life cycle, then that might be helpful. Okay, so oral infections. So there's lots of oral implications that someone with HIV might present with. And of course, really somebody with HIV that's very well controlled, they may look like a vision of health, honestly. I mean, if they have taken their medication and their medication is working very well for them, there may be very little that they stand out very with not a lot of differences to your patient who doesn't have HIV or AIDS. Probably more HIV is where we should draw the line, because more patients would be in that category, won't have gone into the category with AIDS, because we are so well controlled now with the medications. But if somebody is well controlled, then they might not appear to be very unhealthy at all. So a lot of these things you would see in somebody who is not taking their medications, is not well, the medications aren't working for some reason. So you'd see these fungal infections, you'd see the more times that they would express the herpes simplex virus. Their body wouldn't be as good as kind of fighting it or suppressing it. So they'd have more breakouts of like the herpetic lesions, hairy leukoplakia, the papilloma virus. So the little intraoral warts that people can have, they look like, usually they're sort of like a roundish shape, but they have all these little fingerling projections on the top. The surface is kind of like lots of little sort of finger-like projections at the top of the lesion. Bacterial infections, periodontal disease is not going to be as well controlled. Canker sores, aphthous ulcers, the petechiae from anemia, xerostomia from, a number of things, possibly medications as well. And then the oral neoplasm, which is the Caposi sarcoma. So that is, and we'll go to that in just a second, but that can be anywhere on the body, but it can predominantly, people can see it in the oral cavity, but that can appear on the arm or, anywhere really, because it is affecting blood vessels and the lymph system. So here's just a picture of thrush. It's just an image of thrush there. So here's an image of the Caposi sarcoma. So you can see here, it's like on, whatever body part that is, the arm or something. And then here it is on the palate. So it's considered kind of a defining illness for AIDS. This is something back in the 80s and 90s before they were so well controlled. Patients would show up with this and they were like, at first, like, why is this happening? And then the more they started to understand the epidemic and what was happening, then it was kind of like a big sort of defining illness or big warning sign, like, oh, we better test them, for HIV and AIDS. So this means that when the Caposi sarcoma occurs in someone infected with AIDS, that person officially has AIDS. So it's gotten to a point, usually you won't see this on somebody at all who's well-controlled HIV. This is like end stage. They've gotten to the AIDS point of their illness. So Caposi sarcoma is a cancer that develops from the cells that line the lymph and the blood vessels. So that's why it can show up like anywhere. And it can be benign, like it doesn't necessarily mean that all of a sudden they need to go and, have a whole bunch of really strong chemotherapy or anything. So it can be a benign. It usually appears as tumors on the skin or the mucosal surface, such as the inside of the mouth. And they can just, like I said, they can be anywhere on the body. And then they can be different colors. They can be kind of purplish or reddish or brownish. It just depends.
You said cancer that lines the lymph of the blood vessels?
Yeah, so lymphs and then blood vessels. So that's why you can see it anywhere in the oral cavity, because we got blood vessels all over the place, right? And then, but I mean, like you think of all the little capillaries, your veins, your arteries, everything that does anything to do with blood, a sarcoma can develop. And then the lymph as well, so all your different lymph chains. So it can be like hard nodules inside the body as well. It becomes dangerous when it has to do with some organ. So I want to say it's like kidney and liver, and it can't even really remember all of it. It doesn't really affect us so much, so we don't have to know that for exams. But when somebody has Kaposi sarcoma that is significantly affecting some vital internal organs, that's when it's really a problem. If you see just some lesions on the outside of the body, it's usually not such a big deal. A lot of times they have bigger fish to fry. If somebody is this ill, there's, multiple problems going on with their health at that point. Here's some more pictures. You can see it can build up like thick tumors. So, and you can see how it's affecting the gingiva right here. It's the vasculature in this area. So it almost looks like gingival overgrowth, but it's actually like the tumor from around the blood vessels in the gingiva. And then on the palate there. Here's a picture of hairy leukoplakia. Okay, so anyone have any questions about HIV and AIDS? We talk about it a lot next semester too, with more of we'll talk more about the oral stuff, because there's more than just that. Mostly it's kind of to understand the drug, but it's important to know the signs, but we'll talk more about oral signs and symptoms next semester too with HIV.
Do you want us to know a lot about these signs and symptoms, or just know that these are signs and symptoms? Because there's not a lot of information.
Yeah, I just want you to know that they're there. So knowing that you can find this kind of this can be expressed in the oral cavity. There could be a question that says, your patient, I mean, I have no idea. This is not necessarily a real question, but just if it says something about your patient presents with a hard purpley, lesion, on their palate, what could this be? And then you might have a multiple choice that says, aphthous ulcer, sarcoma, blah, blah, blah. So just being able to pick out that, oh, I know that this is purple. I know it can be intraoral. So you don't have to really know much more than those things. Because like you said, there is not a ton of information on the slide. So it's more just recognizing these oral manifestations really at this stage. And then we'll talk about it more next semester. Bacterial infection. So tuberculosis. Did anybody watch this video? Because I was like, I started watching it. I was like, why is this video in this PowerPoint? It was just kind of funny to me, but I left it in there. But then I realized that it was because through the video, you see Doc Hollywood sweating and clammy and gray and breathing heavy, and just so those are some of the signs. So signs and symptoms. So basically, Doc Hollywood, for anyone who didn't watch this, this video is Val Kilmer playing Doc Hollywood in that movie Tombstone, and he has all kinds of funny like one-liners that have come out of that movie that Val Kilmer said. But in real life, Doc Hollywood was he was a gambler, kind of Wild West / dentist. Don't know if I did not know that until I looked it up. He stopped doing dentistry when he was diagnosed with tuberculosis. But when he was taking care of his mom, when he was like young, like 16, his mom had tuberculosis, but then it didn't express in him until he was in his early 20s. So that's just interesting because that is how tuberculosis can act. So so if anyone wants to watch that at your leisure, that's basically what it is. It's like little clips of Val Kilmer. So the etiology of tuberculosis, so it takes prolonged exposure to acquire it. So you have to be caring for somebody, you have to be in kind of close contact with somebody to get it. It's a bacterial infection. It's caused by the Mycobacterium tuberculosis, and it name indicates its formation of firm nodules, or that's the tubercles, or I don't know if I'm saying that right, tubercles, I don't know, throughout the body. So you can actually get these anywhere, but we think about tuberculosis, we think about the lungs, because that's, obviously going to be a major problem when there's when they're in the lungs. But for instance, somebody might have these firm nodules somewhere, maybe like in their, it might be manifesting itself in bone, and then they could have bone pain. But so often we think of tuberculosis and we think of the lungs. So we kind of just focus on that. Transmittability is through droplets or inhaling the aerosol of somebody that coughed or sneezed. And then, of course, the higher number of bacteria that you inhale, higher likelihood, to contract it. But it's actually not super easy to contract, which is nice. And then individuals may be exposed, but not show any signs. It can live in your system dormant. They call it latent TB for very long time. So, and that just depends on a number of factors if it actually expresses itself. Let me see if I'm missing anything from my notes. So individuals with a weakened immune system. So that's why it's kind of like why it's good to talk about it in conjunction with HIV and AIDS, because someone could be exposed to it, but your body has no problem suppressing it or fighting it off. But somebody that has HIV or AIDS has a weakened immune system. So then their body is not going to have nearly the same ability to fight it off. So that's why it can be more common to see tuberculosis in somebody who has AIDS. Again, we don't see it very much in the US because we have pretty good drugs to treat it. a lot of our population who have HIV are well controlled. So this is something more common sometimes in other countries that don't have the same medical services or access to care that we do. Okay, so the pathophysiology, it can, like I was saying, it can affect any organs in the body, but most commonly the lungs. Droplets are carried to the alveoli in the lungs. And then your defense controls, your own immune system is going to be what controls and contains the infection, and what determines if it's latent or if it expresses at all, or, you know, how long it's kind of lays dormant in your system, depending on, you know, a number of factors. If it's not contained, the granulomas form, they eventually cause necrosis. So if somebody is suffering from it in the lungs, that coughing and all the associated lung problems is because of these tubules that are forming, and then they're actually end up causing your lung tissue to necrose and die, essentially. But like I said earlier, it's not super easy to spread. So you have to spend some pretty close time with somebody over a long period of time to actually acquire it. So a person may contract pulmonary tuberculosis from inhaling the droplets from a cough or sneeze. Granuloma in the lung tissue is what causes the outward symptoms and side effects. Here's a lovely picture of a lung that has undergone some necrosis. And then, so the signs of TB, so somebody might feel initially when they're exposed, they may have like flu-like symptoms, and then nothing. And then they might not know that anything actually happened. So they could just go, you know, maybe have some initial flu, and then it could go into that latent stage. Later, if their TB goes from latent to active, then some of the signs are weight loss, nausea, vomiting, headache, palpitations. A productive cough is what we always think about. You know, does your patient are they sitting in your chair hacking away? And then you just kind of quiz them and say, oh, have you been sick recently? Have you traveled recently? Have you been around anybody who had tuberculosis? And, you know, they'll probably say no, you know, because it's not very common here, but we still want to ask those questions, especially if our patient has a really productive cough. They might just say, oh yeah, I got a flu and this is my lingering cough, you know, but that's part of why we want to quiz our patients about all that. But with the signs and symptoms, we think about it primarily in the lungs, but like I said, it could affect any body area. So someone who has active TB could have other pain in other parts of their body, depending on where the tuberculosis is causing those nodules to grow. Okay, so treatment. So there's pharmacological treatment or management. It's very lengthy. It's incredibly lengthy, and it's difficult. And this could be why I'm just sort of half hypothesizing here, but this could be why tuberculosis isn't completely eradicated, is because the treatment course is like months. And so if patients start feeling better and they are not educated on the importance of continuing that treatment regimen, then if they quit early, then they can, what time is it? Okay. Then they can get resistant. So tuberculosis resistant medications is a thing, and it's been a problem. And so that could be in part why it's not completely wiped out, you know, everywhere in the world. Of course, no active treatment with somebody who has active TB, and then there really is no vaccination. They have not been able to create a vaccine that has any kind of efficacy or works very well. Okay, so the drug medications here. So latent or inactive tuberculosis, the most common therapy is this isoniazid. That is used for both inactive. So if somebody knows they have tuberculosis, it's just not really showing the signs and symptoms, but they want to get rid of it out of their system, then they will prescribe them the isoniazid. But also somebody who has an active form of tuberculosis, they're going to go on more of a 3 to 4 drug regimen. Again, they're going to take typically these 4 medications. I think there's a little variation in some of the other things I read. There was a couple other drugs, but this came up in several different. So I think this might not be in the old PowerPoint. I think just these first 2 is what was in the original PowerPoint. So it's kind of, again, a cocktail. Patients can take it from 6 to 12 months to stay on this regimen, and this regimen can not feel great either. So people might be like, I'm not coughing anymore and I feel crappy because of this side effect, so I'm just going to stop taking it. But then they might not have thoroughly killed the bacteria in their body, and then they get this drug resistant strain of the bacteria. So it's important for them to talk with their doctor. Maybe they can change something or change a dosage or, whatever it may be. But they need to be on it long enough to get rid of the bacteria. So these are the 2. There was a question on the study guide. The isoniazid is highly specific for the Mycobacteria tuberculosis specifically. And then the rifampin is effective against the tuberculosis bacteria, but also other specimens of Mycobacteria that are non-tuberculosis. So this RIF can be used for other things as well, but it is used very often for tuberculosis. Okay, let's take a break. Where are we at? 1:52. What time do we go till? 2:50, right? 2:50. So let's take like an 8-minute break. Let's come back at 2 o'clock. How's that sound? I wonder if I can pause the recording so we're not staring at nothing for 8 minutes. Pause recording. Someone remind me, Zoom recording. Okay, autoimmune disorders. So moving along here. Okay, so rheumatoid arthritis. So this disease, it's essentially inflammation. I mean, the steps here, the disease process, you kind of want to understand, but you can, I mean, in some ways you can relate this to periodontal disease, because all the problems that we have in our mouth with periodontal disease that are kind of kickstarted by the bacteria is our overreactive immune response, right? And so a kind of sort of a similar thing is happening here. We have our body, our immune system is attacking the synovum, which is basically like the lining of the joints. It's attacking it and causing this big inflammatory response. So you have the granulation tissue formation, all those immature cells and everything. So you get all this granulation tissue, which of course, then we have more inflammation, more lymphocytes and plasma cells infiltrate and come to the site because they think they're doing what they need to do, but really they're just making it worse. And then we have more granulation tissue eventually covers. So we have this sort of buildup and thickening of the synovum. And that's what leads to those like pictures where the fingers are really deformed and going and there's lumps and bumps because it's like a buildup of material. New bone and fibrous tissue gets deposited, resulting in fusion and loss of mobility. So that's when you get that really kind of deformed look, especially in the hands. It's kind of an iconic picture that you can think of. Etiology is relatively unknown. Of course, women are far more affected than men. Genetics and environmental factors. If you read up specifically up on it, you can delve a little bit more into the etiology, but for this level, we don't need to get too much into it, just knowing that there's some kind of genetic and environmental factors. The difference between osteoarthritis and rheumatoid arthritis is that osteoarthritis is dealing with the deterioration of the cartilage. So pretty soon you're like bone on bone, where rheumatoid arthritis is an autoimmune inflammatory condition of the synovial tissue around. That's like kind of the cushion and the fluid that gets everything lubricated and working nice. It's that area that's that is changing and degrading and thickening, essentially, not really degrading, but kind of thickening and getting harder. So the joints and muscles ache, painful, there's swelling, usually in the morning when in the individual first wakes up, they're the most stiff. The TMJ can definitely be affected as well. So people can have joint pain and swelling in the TMJ as well. Treatment, this I think is different from the other PowerPoint because this, I looked up several resources and this seems to be some pretty straightforward treatment for rheumatoid arthritis. These disease modifying anti-rheumatic drugs, or DMARDs, are common sort of grouping of prescriptions. They relieve symptoms, but they also slow the progression of the joint damage. So often doctors will prescribe these DMARDs along with NSAIDs, and then also possibly some low corticosteroids for the inflammation. And of course, those also help with swelling and pain as well. So then the corticosteroids, this little bit down here at the bottom of the slide, this was what was left from previously. So the corticosteroids can be, we have to think about those in terms of the dosage and how long people are on those. But the mechanism of action there is to help suppress the inflammation, the migration of the leukocytes, and then regulate the cell metabolism of basically everything that's attacking the synovial fluid or the synovum, try to regulate that and kind of mitigate that or stop that from happening. But I think these DMARDs up here, I just thought this was interesting. Maybe nobody has heard this yet, but has anyone heard the controversy about the hydrochloroquine and COVID-19? Like it's been in the news as people have thought that it actually would help treat early stage COVID or prevent COVID even. And then when I saw it, I was like, it's a rheumatoid arthritis medication. Like, I just thought that was really interesting. Okay, so my thought process is that because the corticosteroids was mentioned for rheumatoid arthritis, even though what I saw in some of the literature said that they might also co-prescribe low dose corticosteroids along with the DMARDs. So I don't know, maybe they used to, maybe it's older treatment of higher corticosteroids used to be more of the go-to, and now they've adjusted and they've gotten better treatments, so this just might be simply a fact of updating the information. But I kind of think that's why Cushing's disease is in this PowerPoint, because this can be something that happens when somebody's on high doses of corticosteroids for a long period of time. Although per some of the literature that I was reading, it can be overuse of cortisol medications, but it can also be because of a tumor, either on the adrenal gland, somewhere else in the body, pituitary gland secreting this adrenocorticotropic hormone. So it seems so out of left field. I'm like, why are we looking at this? Like, how does that? But I think that was why it was there, is because we were talking about corticosteroids. So I think that's why it was there. Nevertheless, it's kind of interesting. There are these very specific changes that happen to the body when somebody has Cushing's disease. And if you can see, if you research it a little bit on the internet and you look at the befores and afters, I mean, the swelling in some people's faces, or like this, what they call the buffalo hump, which is kind of like this deposit on the back of the neck. The changes when they get the either surgery or whatever medications, the change is pretty dramatic. But it's known for these big striations in around the abdomen and other parts of the body too. And then the thin skin, you can see it kind of in this this lady's armpit here. Her skin is kind of folded in. It's very thin and kind of pulls. It's kind of stretchy. But then the swelling in the face, so that it's a very round, kind of swollen swelling in their face. But then they bruise easily. There's all sorts of things. This syndrome does not seem pleasant at all. Treatment for Cushing's disease, these are medications here in patients. So a lot of times a surgery seemed, from what I read, surgery actually seems to be a first line of defense, removing a tumor or whatever might be causing this increase of cortisol in the system. But then if that first line of defense doesn't work, then these are some of the medications that can be prescribed to patients to control the syndrome. Okay, so miscellaneous. I just thought that was funny. It said miscellaneous, and then now we're going to talk about blood. Okay, so kind of have lengthy notes here on the side because I just felt like this was kind of a lot to go over, and I didn't particularly see. I mean, I feel like understanding blood and the components of blood, but unless we're directly connecting it to a medication, I kind of was like, this just seems like a lot of information. But I think if you stick to, like the basic components of what's in plasma, the basic role of white blood cells, the basic role of platelets, the basic role of your red blood cells, I think those are like these highlights. I don't think you need to know. So when you pull up this PowerPoint and you see my very lengthy notes on the side here, don't let that overwhelm you. I'll stick to whatever is in these PowerPoints as the quiz questions and exam questions. But so basically we have the first half of your blood volume, or more than half your blood volume, is plasma, which is basically just the liquid portion of your blood to carry all these other little cells that are inside your blood. So the main job of the plasma is transport, also transports, medications and nutrients and all these other things, and waste as well. And then also platelets and red blood cells and white blood cells as well. Red blood cells start as an immature cell in the bone marrow, and then after about 7 days, they mature into their full-grown red blood cell, and they don't actually have a nucleus. So it's very kind of an interesting cell, but because of that fact that they don't have this nucleus and that they have this very specific shape to help carry oxygen and CO2, it actually makes them very fragile. So they don't live much more beyond like 4 months, something like that. So they get kind of banged around and they squeeze through all these different areas in the body, and then the red blood cell dies. So it has a limited life, but we're always making new in our bone marrow. We're always making new. Let me skip along here. Let me see. Where am I at? Okay, so then white blood cells, oh no, we're going to talk about the white blood cells in the next slide. So we'll just talk about platelets here for a second. So then, so platelets are kind of also interesting. So red blood cells are interesting because they don't have a nucleus. So that's kind of an interesting thing. But then platelets are interesting because they're not really like a whole cell. They're kind of like a piece. They're like a little piece of something floating in the bloodstream that stick together and kind of help patch up areas where we might have injury, but they're not actually like a true cell. So they produce all these tiny little fibrin threads, and they stick together, and they will, if we've had like, an injury, or I'm trying to think of another reason. Do I have something in my notes? Maybe that's the only reason, because they're obviously there for coagulation. So gathering together to the site of an injury, sticking and lining the, so it's just basically for injury. So there are internal band-aids. So they're not really a full cell. They're just like a piece of a cell that will come together and make this kind of fibrin mesh to patch up a injury area. Okay, so the white blood cells, these are our parts of our immune system, our protection, our little fighters, right? They help us fight our infections. There's much fewer white blood cells than there are red blood cells. There's only, is it less than 1%? Let's see what the Yeah, less than 1% of our blood is made up of white blood cells, but they're very powerful and they work hard for us. The most common type of white blood cell is the neutrophil. We have by far way more neutrophils in our white blood cells than anything else. And they're kind of our immediate response cells, and they go right to whatever comes in that's, you know, not supposed to be there. And they're like just the frontline soldiers to get to whatever is going on, infection or what have you. Each neutrophil lives less than a day. They have a very short lifespan as well. And then they also are created, the bone marrow also creates these as well. And we'll see that in the next slide where we look at the stem cells and a little bit of the stem cell process. So the other major type of white blood cell is a lymphocyte. There are two main populations there. There's our T cells and our B cells, or our T lymphocytes, and then the B cells are the other. These are more for a specific immune response. They also produce antibodies. So they all have their sort of job. You can see the eosinophils here. I didn't really mention it in the notes. I don't think I did. No, but the eosinophil and the basophil, they make up far less than the neutrophils, but those are more specifically inflammatory and allergic reactions. So they each kind of have their role, but you can kind of think of the neutrophils as like the workhorse. And then it kind of goes from there. Okay. And then there's the monocytes and the macrophages, and those have diverse functions. So those maybe just do whatever is needed them to do. We don't need to know much detail about those. So as far as blood cell count and what's like normal level or healthy level, if anybody's putting anything in the chat that you are like asking me a question, just unmute and ask me. Oh, go ahead.
Will we need to be able to identify the different white blood cells by how they look?
No, just by like general, I would say, right, you know, like if you're making flashcards, right, eosinophil, basophil, inflammatory and allergic reactions, like just know that. And then maybe, you know, say that it's, maybe know that it's a granulocyte, and kind of predominantly what they're going to be focused on in your body. I think that's about all you need to know. And you don't need to recognize it by what it looks like. That's far too like, what is that? Microbiology. I don't know. You did that already. Don't worry about it. Okay, so white blood cells. So the range of white blood cells in a healthy person, 4,400 to 11,000 cubic millimeters. It's also recorded in like microliters too. I saw that in some of the literature, but that's what the MM3 cubic millimeters. So then you have leukocytosis, which is high levels of leukocytes. So if your levels of leukocytes are above 11,000, you have leukocytosis. This can happen in pregnancy. It can happen for somebody who exercises very vigorously. Emotional stress can increase your leukocyte count, or infection. So something that's stressing your body, basically. I mean, all of that stuff stresses your body: pregnancy, exercise, emotional stress. So if your body's stressed, you're going to work harder to get more white blood cells or leukocytes. And then leukopenia, penia or a deficiency, not as much, lower levels of leukocytes. And that could be early leukemia. It could be because of a drug that affects white blood cells. I know we have talked about a drug that affects white blood cells, and I can't think of what it is. That's going to drive me crazy, and I'll look it up later. But so there's certain medications, and then chemotherapy can do it as well. And that's if you're under 4,400, then you have leukopenia. So true or false, leukemia is more common in children. What do you guys think there?
Yeah.
I thought the answer was true.
It's not true?
I thought it was. Apparently it's not. But the question, I looked up one resource because I thought it was, and I read, it's in my notes here. It says most cases of acute lymphocytic leukemia occur in people under 20 years old. The median age of ALL, which is this acute lymphocytic leukemia, is diagnosed at 15. So then I was like, oh yes, it's true. But then I read a little bit clearer, and it says the risk of leukemia increases with age. So the median age of people who are diagnosed with, there's different types of leukemia. So acute myeloid leukemia or chronic lymphatic leukemia, the average age is 65. So more older people have leukemia, but it's just these different types of leukemia. So there's a leukemia that is seen in younger people, but there's not as many younger people who have that as older people who have a different kind of leukemia. And that's all written in the notes on the PowerPoint, so you guys can kind of see that. And then the next slide here shows 9 times more common in adults than children. So I think it's like these types of leukemia. But a lot of times when we think of childhood cancers, we think of leukemia, which is horrifying. But so leukemia is a cancer of the white blood cells. It's more common in adults, and it causes, the causes are not specifically known. There's various factors and environmental factors. And it can very rarely be a viral thing, but that's not as common as some environmental factors that must be playing a role. Really, they don't have like a hard, fast answer. They know some things that seem to lead to it, but they don't really know what the exact cause of it is. Okay, so I always think when I think of signs and symptoms or early signs and symptoms, I always think of this. I was in a CE course and a hygienist stood up, and very recently her father had been diagnosed and died from leukemia, and it had happened very rapidly. And she was like, as she was telling the story, she was so emotional, and like you could tell like it had happened within like 6 months of her being at this conference. But one of the first signs, like now retrospectively, she's looking back into, you know, when her father had first talked about stuff, and he went from having a very healthy dentition to all of a sudden having extreme bleeding and then rapid progression of periodontal disease. And there wasn't a lot of other things that either he just didn't want to go to the doctor. You know how sometimes people can be in denial of things. They can be like, I'm just tired because of whatever. But he went to his dentist and he talked with his daughter about his mouth, but there wasn't anything else that kind of propelled him to get checked until like, however, you know, a month later or 2 months later. And then he was like in end stage leukemia. And I think he died like within 6 weeks or something. But she was talking about his oral, how it affected his oral health and how severe and rapidly his mouth changed. So that always kind of stuck with me as like a very early sign, or something that, you know, if somebody has healthy mouth and takes relatively good care, and then all of a sudden things are just degrading rapidly, something's not right. I mean, that's just a canary in the coal mine like nothing else. But some signs and symptoms for other things: bruising easily, fatigued, bone pain, oral ulcerations, unexplained bleeding, so gums that are just bleeding, or, you know, maybe elsewhere as well, but the mouth would be a big place. And then pallor, so like white, like white tissue as pallor. So treatment for leukemia, chemotherapy, of course, is a big one, radiation, and then bone marrow transplant. So usually we'll talk about this more in special needs, because there's a lot to talk about, because patients usually get heavy chemotherapy, heavy immune suppression, wipe out their own defense when they go in for a bone marrow transplant, because you don't want your body to reject it. You want your body to accept it. So you have to get very sick and very weak, and then they put in the new bone marrow and then hope that your body accepts it instead of fights it off. So it's quite a process. But with that, some of the oral side effects, and if you guys look at table 9.2 in your textbook. It kind of reviews some good, I liked, I wish I'd put the page number on there, but it's table 9.2. I'm not sure what page it's on, but it has some good, just information, not necessarily stuff that'll be on a quiz or exam. I mean, it could be, but like I said, that's more almost special needs course, not so much pharmacology, but it's just really good information to know, like, what do you do with oral mucositis? Of course, we know what to do with xerostomia and candidiasis. We have some better knowledge and, you know, knowing how to treat that. But some of these other conditions that people have who are undergoing heavy cancer treatment, especially the mucositis, it's just palliative care, but understanding some of the things you can recommend. So 9.2, wherever that is in the book, that's just a good one to just read through for your own knowledge as a dental hygienist, like not even like to think about an exam, but just 159, page 159. So xerostomia, so patients who are undergoing cancer treatment, they'll have a lot of xerostomia. They'll have a lot of, be much more predisposed to candidal infections and mucositis. They can have a little mucositis in one little place, or they can have it everywhere in their mouth and it hurts so bad they can't eat. It just, everything's so uncomfortable. And it's just encouraging them from the get-go before chemotherapy really gets going. Good oral hygiene, keeping the tissue moist, eating foods that are not irritating, rinsing with lubricating, soothing kind of things. There's just like a series of things to try and encourage them. It can be a nightmare for people who have just a mouthful of sores. It's just really painful. But this, of course, is directly affected to like their low white blood count. So that's part of it as well, is why they get the mucositis. Okay, so what time is it? 2:25. Okay, osteoporosis. Oh, we should be fine. We have 10 slides. Osteoporosis basically means like porous bone. There holes, like the density of the bone becomes more open, you know, like the honeycomb, the openings become bigger and bigger. Like the balance between the osteoblasts and the osteoclasts that resorb bone and make bone, the balance is off. So there's more resorption than formation, basically, when somebody has osteoporosis. Chief clinic, a really common clinical manifestation would be somebody who gets a hip fracture. That's like a very kind of common kind of clinical manifestation. Let's see if I have. Oh, and then there also, just on a side note, there are many conditions. And if you look up like the, you know, Association for Rheumatology or something like that, or, you know, just, or even something more specific geared toward osteoporosis, I found some resources that listed all of the different diseases and conditions that can lead to some osteoporosis, and there's a number of them. So it's not, you know, just sort of old age, but it's some other condition that someone might have could put them at higher risk for osteoporosis as well. So prevention in early stages, there's things like, you know, calcium and vitamin D and weight-bearing exercises and, you know, different things like that, that they try to encourage people to build up their bone density and keep it as dense as when you're younger. So when things slow down and aren't as likely to, you know, develop, you know, as we age, things don't work as well. So you kind of have a good setup that you've done your whole life, hopefully. But of course, again, postmenopausal women are going to be at higher risk. But they have shown that when women do weight-bearing exercises, that helps. That, I think it must have something to do with, it's kind of like when you think of ortho, it's like pressure on one side helps to build up, or, you know, the basically like the pressure on the bone helps to initiate the formation on some level. I don't know, I'm not an expert there, but they've shown that to have a positive effect. So the main medications nowadays that patients take are they're called bisphosphonates. That's the classification of the drug. And they're basically an anti-resorption medication. So they help the body to limit the activity of the osteoclasts. So that's the first line therapy for prevention and treatment. There's oral, and then the intravenous is far more commonly used for patients. They also use bisphosphonates for cancer patients who have hypercalcemia. They're trying to get calcium out of the blood, I believe, if I'm remembering it correctly. And so they will give them intravenous, much higher doses of bisphosphonates intravenously. And we'll talk more about the complications for that in just a second. But people with osteoporosis, kind of garden variety osteoporosis, they usually take a much lower dose of a bisphosphonate, and it's usually the oral variety. So here, the mechanism of action, it mimics the pyrophosphate, and it's an endogenous resorption inhibitor. So it's inhibiting that osteoclast activity. All bisphosphonates become incorporated into the bone matrix. So this is a very important thing to know about bisphosphonates. Remember when we talked about half-life, like the half-life of a Tylenol is like hours? The half-life of a bisphosphonate is years. Matter of fact, a decade. So it gets into your bone and it is there for a very long time. And this is not a bad thing in general, but we have to be very aware of it when we think of this next complication that we'll talk about in just a second, the osteonecrosis. And there's a key factor there that kind of has to do with that. So we'll talk about that in just a sec. I put this one in, no, this was here already in the PowerPoint. I put this one in. They're very similar. I just felt like maybe this one had a little bit, I see Boniva and Fosamax and Reclass. I have seen that far more commonly than a couple of these, like the Scalid and the Iridia, or however you say that. I haven't, and then this one, the Didronel, I hadn't seen those in practice, but then when I saw this list, and that's not to say that people aren't taking them. I mean, I've only seen a small fraction of patients, compared to the world, but I just liked this list because I was like, oh yes, I've seen these ones. And I also liked how it said daily, weekly. This one's taken only monthly. This one's taken intravenously every 3 months. This one's taken once a year intravenously. And then this list talks about the potency factor. So I wasn't sure I just didn't know what the frequency and the potency factor related to, because I didn't know where this originally came from. You know what I mean? So I was like, well, I like how it says that it's by mouth or IV. That's great. But I didn't really understand what the frequency and the potency factor related to. So that's why I pulled this one up. And if I find that there is a quiz question or an exam question that specifically relates to this, I'll be sure to let you guys know, because I really don't understand why it's there, frankly. And if you do, tell me. Put it in the chat. So these are medications, brands and generics that you will likely see in practice. So it's important. Fosamax is a biggie. That's why it's in red. So just make sure that you're very familiar. Boniva, like I said, Actonel, I've seen, and then what was Reclassed, I've seen that as well. So just being familiar with those medications. Adverse effects, mostly just GI, some abdominal pain, nausea, not a big deal. But the biggie that we need to be very aware of is the osteonecrosis of the jaw. There's different there's radio, there's when some people have radiation, there's osteonecrosis that they can get from the radiation. That's different. We'll talk about that next semester, but this is just osteonecrosis of the jaw from bisphosphonate use is pretty much what we're zeroing in on. You're going to see this generally predominantly in patients who have had high doses and IV delivery of the bisphosphonate. Not nearly as common of somebody who has osteoporosis and is taking Fosamax, like a lower dose of Fosamax. We still talk to them about the possibility that of these osteonecrosis, but far, far less likely. They're much more likely to have this complication if they're a cancer patient. Basically, what you're seeing is the jawbone. So what happens is some bone gets exposed and the tissue just won't heal over. There just won't be healing. I've seen patients have an exposure of the bone. All the necrotic bone and the necrotic tissue is cleaned away and they will graft it. The patient will keep it extremely clean and it still will not heal over. They will just have exposed bone. I've also seen patients who have managed to get it covered up. So it just acts different. It can be very aggressive and incredibly detrimental, and they have to keep resecting jaw, or it can just be like a spot that's just like, there it is, and we just can't make it go away. So it can act very differently, and it just has to do with the person and their host response to it. But that's what's the picture is there, and there's some more pictures here in a minute. But basically the mechanism of what's happening, it's related to the suppression of the osteoclast activity. They don't entirely understand why it happens, but they just know that these very, very high doses of the bisphosphonates that are in the bone are somehow, because of whatever the good thing they were doing that had to do with the osteoclast activity, there's just, like with anything that's a pharmacology, there's sometimes good stuff, and then you have your bad side effects. And so, that's the very, disadvantaged side effect of this mechanism of action. Unable to well identify those at risk, although actually the literature says it's much more likely someone who's cancerous, but then in that group, it's hard to know. However, we know that if somebody is about to undergo IV bisphosphonate treatment, like they're a cancer patient and they're about to undergo it, everything that's dentally related has to be done before they start treatment. All periodontal disease should be under control. Their home care should be immaculate. There should be no teeth at risk for having to be extracted for any reason. If they're going to have an implant, it must be put in prior. I mean, literally, they never want to have another extraction or implant or any kind of oral surgery again. And of course, that's a very difficult thing to guarantee, but the doctors would just do their best to ensure that happens, that their oral health stays as healthy as possible. And that's how you kind of mitigate the risk the best you can. Sorry if I'm talking a mile a minute, giving you guys too many things. So possible risk factors: potency of the bisphosphonate, high dose IV. Just think high dose IV cancer patients, they tend to be higher risk. Oral surgery, so somebody who ends up with a resection of their jaw because of cancer, or a tooth has had to come out because of fracture or decay or something like that, an implant, all of those, any kind of surgery can initiate it. And then oral disease, history of inflammation or dental disease, periodontal disease that is kind of, not stable, it could initiate it as well. So those are some risk factors. And here's just a couple different images. There's like just a small hole here, oh, my thing's in the wrong place. Small hole here, massive area here, moderate here and here. It just can look different ways, and it can be in different areas, but generally it's wherever, like they probably had a tooth extraction here and here. And that's it. You guys have any questions? I know that was a ton of information. We are 12 minutes ahead of schedule, so you guys can ask me questions. We're done. So whenever anybody wants to log off, go ahead. But if you guys have questions, I'm going to stop sharing and just look at the Moodle page here.
Hey, Leslie, quick question.
Yeah.
So for the herbal medications, we just need to go over it by ourselves and turn in those study notes tonight.
So herbal medications, hold on. So, okay. So herbal medications. So who regulates the use of herbal medications? Does anyone? We'll just go through a few of these if you want to. Dietary Supplement Health and Education Act. The first, I'll give you a hint. The first three, you can get a lot of that right out of the abstract. So read the abstract. And then the middle questions, look for the headers in that article. If you don't want to read all 11 pages bit by bit, the headers will give you kind of where to look. So list three of the most common oral manifestations associated with herbal supplements. The headers of that article will say like oral manifestations, go right to that section of the article and just peruse it. It's pretty easy to fill these out. And I've already uploaded the key. So there's that.
Okay, thank you, Leslie.
You're welcome.
Hi, Leslie.
Hi, I'm gonna stop recording. Hold on just a
Okay.
second.